Okay, so the first case is a voided urine specimen. This is from an 81-year-old male who had a past history of urinary bladder high-grade papillary urothelial carcinoma, as well as the urothelial carcinoma in situ. So this is a follow-up urine specimen. So the cellularity of this specimen is quite low. So basically, this is very common in the voided urine specimen because not every urine will have a lot of cells, because majority of the cells were exfoliated. So sometimes they would have a lot, and sometimes it's just a little bit. So in this specimen, we have very few cells, but some of the cells do show cytologic atypia. So here is a relatively normal umbrella cells here and here, and there is a cells with a little bit bigger nuclei, and the shape of the nuclei is triangular, but it's difficult to appreciate the NC ratio. So they are indeed a few atypical urothelial cells, but the main issue is this urothelial cluster. For the voided urine, usually there is no fragment of the cells. So if there is a fragment of urothelium, first of all, you need to confirm that whether this is a washing cytology. Occasionally, you will see fragments of urothelial cell in voided urine specimen, but it is more common that you will see in the patient, for example, have a renal stone. So the stone will like scratching the mucosa, and they then like exfoliate as a piece, as a large fragment in the urine specimen. So here we have a larger fragment of the cells. When we make diagnosis of high-grade urothelial carcinoma, we usually feel more comfortable that we can identify a typical single cell rather than a larger fragment, because the larger fragments, if it's difficult to evaluate the nuclear chromatin pattern as well as the NC ratio. But this fragment is what we have now only. So usually we will go to the periphery of the fragment. So if it is a benign fragment, usually you will see umbrella cell lining at the periphery of the fragment. I think for this fragment, we do appreciate that majority of the cell do show hyperchromatic nuclei, some with kind of coarsely granular chromatin pattern, and the NC ratio of these cells are indeed increased. It's very high. Additionally, there seems to be some individual cell like a chorioresis pattern within the fragment. So I think at least we need to call this suspicious for high-grade urothelial carcinoma. So the patient do have recent image study. CT scan suggests that there is a papillary lesion in the bladder, which is compatible with the recurrence of the prior history of high-grade urothelial carcinoma. So I think based on this clinical information, we can call this positive for high-grade urothelial carcinoma. Okay, so the diagnosis is basically integrate the clinical and image study as well as the cytology that we have here. So the take-home message is that usually in the urine voiding, particularly voiding urine specimen, it's kind of difficult to interpret the urothelial fragment. Majority of the fragment is benign, but sometimes we will also see these highly atypical fragment that is consistent with the papillary urothelial carcinoma. So then we move to some body fluid specimen. First is a 48-year-old male who had a past history of lung adenocarcinoma, and this is his pleural effusion specimen. So the specimen is showing a low cellularity, but on low power you can appreciate there are some very big single cells. So when we go to higher power, there is a nice contrast of relatively benign, perhaps histiocytes over here. Then these highly atypical cells show much increase of the size of the nucleus, eccentric nucleus, prominent nucleoli. So this is consistent with a poorly differentiated adenocarcinoma. So there were quite a few these highly atypical cells in the background, mostly in single cells. So again, a very atypical cells. So this is consistent with a positive adenocarcinoma and compatible with the patient's history. The next specimen is also coming from the pleural effusion specimen from a 70-year-old male. This is the patient with a past history of also lung adenocarcinoma. So on low power, there are not so many cells. We have some proteinaceous background, but they do have some very big cells cluster here. So again, this is consistent with a poorly differentiated adenocarcinoma. These cells very big, gigantic cells with very distinct and prominent nucleoli. So this is also consistent with the patient's disease of high-grade adenocarcinoma of lung. So the next case is also a pleural effusion specimen coming from an 81-year-old female. The patient do have a different history that she has a cholangiocarcinoma from the common bile duct. So in this pleural effusion specimen, we can appreciate they are small and tight, like a tubular structure. And the nucleus of this cell is not as high grade as what we see for those prior to lung adenocarcinoma. So it's relatively more bland looking compared to the prior cases. So this is relatively common for the cholangiocarcinoma or well-differentiated pancreatic adenocarcinoma, that it frequently will show these low-grade tight tubular morphology. But indeed, we can find some of the area do show prominent nuclear atypia, vesicular chromatin, and polymorphism in a very tight three-dimensional cluster. So this is consistent with metastatic adenocarcinoma and compatible with the patient's history of CBD, common bile duct adenocarcinoma. So the next case is from a 75-year-old male. Again, pleural effusion specimen. So in this specimen, they were very rare tumor cells. But our screener do a very good job by identifying these. So these cells looks very different from what we see before. So it shows much more hyperchromasia as well as very high NC ratio arranged in these like molding or cell in cells type of pattern. And when we can have a better appreciation of the chromatin pattern, the chromatin pattern do show very fine granular pattern comparing to the vesicular pattern. So this is consistent with a small cell carcinoma. So the patient do have the confirmed history of small cell carcinoma of the lung. And during the treatment course, sometimes they will only have very, very scant tumor cells in the specimen. But here we still see the small cell carcinoma component. This is probably the most convincing cluster. And this type of specimen is relatively difficult to screen, but on the requisition sheets, the clinician already mentioned that the patient has a history of small cell carcinoma. So, so for this case, usually we would spend more time on the screening, and there's only one single cluster of tumor cell over here. So small cell carcinoma is sometimes not easy because of the scant cellularity. So the next specimen is a CSF specimen coming from a 56-year-old male. So this is coming from the brain, from the CSF fluid. And here on low power, we can already see a lot of brain parenchyma tissues. So these are all brain parenchyma glial tissues in larger fragment. When you see something like this, we realize that the patient must have a surgery in the brain. So the CSF is not like a taping from the spine, but possibly from the surgery procedure itself, because they are fragments of the brain tissue. And usually in this scenario is that the patient had what we call VP shunt, ventricular peritoneum shunt that was set for the releasing of the intracranial pressure. So in this situation, usually the patient will have some lesion in the brain, so they need to release the pressure. So just right next to this brain parenchyma tissue, we already see some cluster of cells have these atypical features. Increased NC ratios, vesicular chromatin, small but distinct nucleoli, eccentric nucleus. So this looks like adenocarcinoma poorly differentiated. So the patient has a metastatic adenocarcinoma in the brain, in the meninges, and causing the obstruction of the ventricular floor and increase the intracranial pressure, so they need the VP shunt to release the pressure. So here we do see intracytoplasmic vacuole pushing the nucleus to one side of the cells. And some of the vacuole demonstrate features of mucin. So here we have a cell with a vacuole and with the original like a staining here and here as well. So this looks like mucin. So the tumor cell actually have some intracytoplasmic mucin, which is very uncommon in lung cancer or breast cancer, which are the two most common cancer that would go to the brain. So when we take a look of the history, the patient had pancreatic cancer. So this is relatively uncommon for the CSF metastasis. But because of this mucinous feature, we realize that this is likely not from the lung or from the breast, and this is compatible with the history of the pancreatic cancer. So this is metastatic adenocarcinoma, likely from the pancreas. So then we move to defining the aspiration. First is thyroid. On low power, we don't see colloid. We have some blood and some larger fragments of cells, mostly in the flattened monolayer sheets. Additionally, just in this power, we can already see a few multinuclear giant cells. So over here and over here. So we do have some multinuclear giant cells. And here we have some fibrovascular cores. So this looks like a papillary architecture. So overall, just on this low power, we know that this is highly likely to be a papillary thyroid carcinoma. So what we need to do is just to go to the higher power to see if we can identify the nuclear feature. So here we do see the nucleus are mostly elongated in oval shape, and some of them show grooving. So additionally here we do identify a cell showing a nice like intranuclear pseudo-inclusion. So this is consistent with papillary thyroid carcinoma. So the final specimen is coming from imprint cytology of a lung biopsy. So usually for the imprint cytology, we will get some significant drying artifact. So for these specimens, we can appreciate that they are monotonous population of these cells with a glandular type of features. So some are loosely cohesive, but mostly into one cluster. And for the loosely cohesive cells, it does have some eccentric nucleus here and there. Additionally, we can appreciate some of the cell seems to have an intranuclear pseudo-inclusion. So for the primary lung adenocarcinoma, it is not uncommon that we will see the intranuclear pseudo-inclusion. For this patient, the patient actually had a history of a breast ductal carcinoma, and the image findings show multiple tumor in bilateral lung. So clinically, this is more likely to be metastasis of the breast cancer. So just by the cytomorphology, we will be difficult to determine if this is a primary lung adeno or it is a ductal carcinoma coming from the breast. So we would just call these non-small cell carcinoma, and the clinician can refer to the biopsy report regarding the immunostain to confirm the origin of this lesion. So that's for all the case today.